So we're doing IM today. So, Mr. Sponge, what I'm wanting to do is I'm wanting to give you 3 mils worth of saline. Is that alright? The risks of this could possibly include me missing the site and causing a puncture wound, but the benefits of it will be you get saline in your body. Do you consent? Great. My PPE is appropriate. I'm currently wearing gloves, I'm wearing face masks, and I'll be treating sharps appropriately. So what I'm going to do is assemble the necessary bits of kit. You can see I've got my saline, cleaning sponge, my giving needle and syringe, and, sorry, my drawing up needle and syringe and my actual giving needle itself. So I'm going to be choosing a correct site. It might depend on the amount of drug that you need to give and also the vascular properties of the muscle itself. You can choose from vastus, lateralis, deltoid, and I'll just be giving the sponge today. So I'll be checking this drug. This is saline, 0.9%, 10 mils, expires 2019. My ampule is intact, my liquids are clear. Offsider, can I get you to check that for me, please? So I'll be starting to clean this up here now. Moving in a circular motion, moving outwards. Nothing is allowed to touch that site now. Offsider, how is that drug?
The drug is not expired, the drug is fine.
Drug is fine to use? Okay, thank you for cracking the lid. So I'll be drawing up fluid. Sharps out. Alright, so I'll be drawing the full 3 mils today. Alright, I'm wanting to give this patient 3 mils of IM saline. Can you confirm that procedures indicate that this is the indicated method for this patient? Indicated requirement for this patient?
That is correct.
Thank you. So I'm just going to be putting this away. So when we are actually injecting the patient, we'll be using the Z-tack technique. That pulls the layers of skin apart and essentially means that when you release the tension, tension comes back. Okay, patient, I'm wanting to stick this needle in your thigh. It'll be relatively soon. Is that still alright? Okay, sharps out again. Alright, cool, we're alright to go. So I'll be putting a bit of tension on the skin, pushing the layers, pulling the layers apart, and plunging it straight in, 90-degree angle. Pulling it up. I am not seeing any blood here. I do not believe I've inserted this needle accidentally into systemic circulation. I'll be putting the liquid in relatively slowly. This is simply due to the fact that muscles have a set volume and you're inserting liquid into that limited volume. You'll create pain and a lot of discomfort if you put liquid in too quickly. Offsider, can I get you to document the time of now, please?
Documenting time.
Thank you. So Offsider, we'll need to check for any allergic reaction. I just want you to have that suction ready for me, please. Can I get the suction as well?
Suction ready?
Thank you. Sharps out again. Sharps away. Yeah. So we're doing adult LMAs. We've already pre-assembled some of the equipment. I have an OPA in, which is the right size. I've got my offsider ventilating at 1 breath every 6 to 8 seconds. I've got my suction round on this side here underneath the neck, and I've also pre-prepped my securing device. So what I'm going to do now is because I have my suction ready, I'm just going to be checking that I have the right sized LMA. Right sized LMA, the lines on here should approximately match up with the teeth. I believe that this is the correct size LMA. My cuff empties fine, my cuff inflates fine. No leaks, no deformities. Emptying it all the way out. This is a size 3 cuff with a 20 ml volume for blowing it up. So the reason why I've got my offsider doing this here is we're going to be pre-oxygenating the patient for 2 minutes. Obviously, playing around with the airways devices are going to potentially reduce oxygen saturations. So this is just a way to essentially make sure that they're alright in advance. Okay, So, just lubricate this up, over the back, a little on the tip. Make sure we're all nice and lubed up. Alright, so offsider in a second. I'm going to be putting this LMA in, the size 3 LMA, 20 mils tidal. Everything's ready here, I'm ready to go. Can I get you to stay over there, right? Okay. Everything's ready there. Can I get the bag valve and mask in about 3 seconds?
Yep.
Thank you. I'll get you to check for chest rise.
Yep, seeing chest rise.
Yep. If I didn't see any chest rise, we would obviously check our dopes, dislodged obstruction, pneumothorax, equipment failure, and stomach distension. So I'll just check that now. Okay. So can I get you to take over this here again? Secure airway, just trying to move it around as little as possible. At the moment, alright, I got my mask on. I have it relatively secure, not too tight, gives me a chance to move it as and when required. So still going 1 every 6 to 8. I'll tighten that up. So in a second we're going to swap over to a cold connector. Alright, I'm happy putting it in that way and that way. Yep. Alright, so we're just going to continue going at 1 to 8. I still have my suction ready. I've got my securing device in. LMA is still not dislodged. And I'm just going to check. So auscultating chest, I can hear chest. Are you ready? I cannot hear any gastric inflation. I'm happy with that. So doing pediatric LMAs. So we've actually started this scenario halfway through. As you can see, I've already raised my ped into the sniffing position. Sniffing position is slightly different simply due to development of the occiput. I've got an OPA in, which is sized correctly, and I've got my patient, and I've got my offsider doing it at a rate of 1 breath every 1 second. That is 60 breaths a minute. So, sizing OPA, yeah, that's roughly the right size OPA. My suction's also there, just in case. This is a size 1. It takes 4 mils to inflate the cuff. I'm going to test the cuff now. Cuff looks roughly correct. Inflating the cuff up to full. I detect no leaks. My cuff looks well. I'm now going to empty my cuff all the way out. Cool, mate. Gold standard is to pre-oxygenate patients for at least 2 minutes before you insert a LMA. That is doubly so for your neonates, simply because they're so oxygen dependent. So mate, what we'll be doing is we'll be putting the LMA in soon when I call for it. So I want you to, when I say, I want you to stop, pull the OPA out. Cool, mate. Alright. So I'm now ready. I have my syringe attached. My syringe is got 4 mils in it exactly. I don't have a securing device that's actually the correct size for the neonate. They're simply too large for the baby's mouth. Alright mate, whenever you're ready. So 3, 2, 1, remove. Okay. Using a tongue depressor, I'm going to depress the tongue. Insert. To attach this, and we'll check for chest rise. I see chest rise. Do you see chest rise? Yep. So we got chest rise. I'll get you to take over there, mate, please. Okay. Keep that as still as possible. As previously mentioned, we don't have a TT tube small enough for a neonate. We'll be using tape, using either a 2-ladder or 3-ladder technique, wrapping it around the patient's mouth and essentially securing the device. So we'll be keeping on ventilating at a rate of 60 beats a minute, mate. 60 breaths a minute, sorry. Okay. So had we not achieved a proper chest rise, we'd obviously check for dislodged, obstructed pneumothorax, equipment failure, and any stomach distension, which we might do in a second. Just to confirm that we haven't wibbled around too much. Okay. Down, down, down. And we're good. The reason why we don't use a suspension device is we're worried about tidal volumes. Basically, we don't want the space of the dead air, which is the air inside the LMA at the moment, to exceed the space of the lungs. And just to finish it off, I hear chest rise. I do not hear gastric inflation.